Chest imaging number 9, prepared by Prof. Sharaf and revised by Prof. Sabri. This will be for the pleura. Pleural diseases may be due to effusion, masses, or pneumothorax. For effusion, you will find meniscus sign, laminar effusion, fluid in the fissure, subpulmonic effusion. Again, pleural disease may be due to effusion, which may be simple or loculated or complex. Pleural masses including plaques, primers, as mesothelioma or metastatic disease, and lastly pneumothorax. Pleural effusion may present as meniscus sign or laminar effusion or fluid in the fissure or subpulmonic effusion, which might need a CT or simply lateral decubitus film can do. Types of pleural effusion include exudate, transudate, and chyle. May be simple or empyema. So we have the content, exudate, transudate, and chyle, or we have simple effusion, free layering with changed position, that means it can move, and no pleural thickening, or empyema, which is usually loculated, smoothly thickened, enhancing margins, and they call it the split pleura sign. So the visceral and parietal pleura are split and may have air within, and there are usually multiple loculations. CT is useful for unexpected effusion and for detection of loculation. CT is usually needed for unexpected effusion or for those with loculations which are not seen, to exclude loculations. So all together we have either exudate due to infection, transudate as in congestive heart failure, chyle sometimes, but rare. It may be simple as free fluid without thickening of the pleura, or it may be loculated, and the best to detect loculation is the CT. And in loculation we can find thick pleura, and the visceral and parietal pleura are split, and this is called the split pleural sign. Simple effusion on X-rays, CT, and US. The earliest sign is the laminar effusion or the blunting with CP angle. The lateral film, of course, is more sensitive because it flows up. The posterior costopharyngeal is more inferior than the lateral one, so this is the most common to start in. Small effusion can be seen on a lateral X-rays in the posterior costopharyngeal angle. So altogether, the earliest sign is the obliteration of the CP angle and laminar effusion. The lateral is more sensitive. Why it is more sensitive? Because of two things. First, that it elucidates and shows the posterior costopharyngeal angle better than the lateral recess, and that's why and this is the most inferior, and because this is more inferior than the lateral one, so any effusion will collect there. CT for occult effusion, to detect effusions which are not seen and to evaluate the size of the effusion, and as we said, for suspected empyema, thickening and loculation, or suspected masses. Of course, loculations are good to be seen, better seen by ultrasound. Obliteration of the costopharyngeal angle, rising to the axilla and complete opacification of the right hemithorax. Here the amount from left to right is 200, 2000 and then 5000 mil. Laminar effusion, splitting the visceral and parietal and containing fluid in between, or in the loose connective tissue between the lung and the pleura. This is rare. Same for fluid in the fissures. Fissures are split and fluid runs in. Normal fissure is the thickness of a sharpened pencil line. If you have thicker fissure, that means that there is thickening, pleural thickening or fissural thickening, or fluid starts to accumulate. So the fluid may collect in any major or any minor or accessory fissure. Especially we should be aware of the azygous fissure. So laminar effusion collects between visceral and parietal, or in the loose tissues between the lungs and the pleura if there is a pulmonary process, pulmonary inflammatory process. And the same occurs in fissures. Fissures are split and fluid comes in, accumulate, causing thickening. The normal thickness of a fissure is sharpened thickness of a sharpened pencil line, very thin line, but it may be more thick if fluid starts to collect. Thickened fissure and pseudotumors. This one is called pseudotumor because it appears and disappears. It's not a tumor. This is the fissure which is more thicker than a pencil line, and here is the fissure within the the posterior part of the oblique fissure with fluid collection, and here is the transverse fissure with fluid. Different cases of fissural collection, and these are called pseudotumors. Both hemidiaphragms are elevated. More on the left, and there is abnormal opacity at the left region. If we do lateral decubitus, it will show good the subpulmonic effusion going up on both sides. Although on the right side there is nothing appearing, yet you can detect it by a decubitus film. Of course, CT is beneficial or has its role in detecting a small amount of pleural fluid. If we consider that the right copula of the diaphragm is higher than the left copula with one space, so more than that, you should expect ascites pushing up, lower lobe atelectasis, diaphragmatic paresis, and subpulmonic effusion, and CT will be of help in detection and elucidation of subpulmonic effusion. So ascites can push the diaphragm up, left lower lobe atelectasis, mainly lower lobe atelectasis, not left, only lower lobe atelectasis, diaphragmatic paresis, and subpulmonic effusions. And subpulmonic effusion usually collects if there are no adhesions. We can find lateral peaking of the diaphragm with inferior displacement of the gastric bubble on the left side. Effusion, filling most of the hemithorax with thickening. You should exclude malignancy, whether primary as mesothelioma or secondary. You should exclude empyema due to infection, for example TB. You should exclude the presence of hepatic disease or pancreatitis. Of course, history of trauma should be searched for, as sometimes hemorrhage may cause massive effusion. So in this one, there are bossy outline of bossy thickening of the pleura, a case of mesothelioma. Here it is simple effusion due to cirrhosis, and here hypoproteinemia, and this one is due to infection, TB, and this one is due to hemorrhage, and you can easily see the heterogeneous density within the collection due to blood. Bilateral pleural collection, CT will confirm. Ultrasound is better for showing locutions of empyema. The meniscoid appearance is seen in the chest film, but the CT is easily can detect, and CT also can easily detect empyema as thickened split pleura with locutions seen in ultrasound. Ultrasound shows better the septations. CT is better to show early effusions and to show and diagnose empyema by three signs: splitted pleura, thick pleural outline, and the presence of locutions. Empyema pus localized to the pleural space. It appears as loculated elliptical pleural collection with convex margins, which does not change on the cubitus position, fixed, uniformly enhancing, limiting the visceral and the parietal pleural layers. Split pleural sign. So here we have the split pleural sign, the thick partial enhancing, the compressed lung around, the air fluid sometimes, and the appearance of a mass in chest X-ray, but the chest X-ray posteriorly shows the mass collecting, and of course this you can get it as a parapneumonia or due to trauma or due to post-thoracotomy. Mediastinal vertebral or chest wall infection extending into the pleura can cause the same. So together, everything together, empyema is pus collecting within the layers of the pleura, visceral and parietal. So it is causing split pleura sign, and split pleura sign act as a mass, compressing the lung surrounding, but it is extra pulmonary. That means that its line with the pleura is forming an obtuse angle, and it may show fluid, and definitely should be thick enhancing margin, should have thick enhancing margin, and it may be seen as more than one loculus. So here it's anterior, pericardial, and in the fissure, as well as posterior. We find 4 locations for the collection. Left-sided subclavian venous catheter. Here it is. Posterior right side sharply defined large air-filled loculus. That one, air fluid. Abscess or pleura, meaningly is it pulmonary or extrapulmonary? Simply there is spread pleura sign, there is thick outline, there is enhancing outline, there is air within, there is compressed lung tissue around, and there are loculi, and there is another one there confirming the presence of multiple empyema. Of course, here we can find minimal pneumothorax on the left. Empyema and bronchopleural fistula and lung abscess. Multiple abscesses suggest septic emboli. Empyema is elliptical, smooth margin, obtuse angles. Bronchopleural fistula, as we said, obtuse angles. Bronchopleural fistula is communication with the airway. It will not stop except if you do surgery. Causes post-surgery: ischemic breakdown of the bronchial stump, infection as subpleural rupture of focal TB or bacteria or an abscess, neoplasm if it is invading. Imaging, we find drop in the air fluid level. So the previously known air fluid level will drop because of the fistulation, and developed air in the post-pneumonectomy place, shift of the mediastinal back. CT and the ventilation scans will show retained radioactivity in the washout images, indicative of bronchopleural fistula. What is the definition of bronchopleural fistula? Bronchopleural fistula is communication of airway and pleural space. What are the three most common etiologies of bronchopleural fistula? The most common etiologies are post-surgery, infection, and neoplasm. Post-surgery, infection, and neoplasm. What are the radiographic findings would you expect in a case of post-operative bronchopleural fistula? Drop in the air fluid level, developed air in the post-pneumonectomy space, shift of the mediastinal back, and we can diagnose it by presence of retained radioactivity in the washout. Abnormal collection of gas in the right lateral chest wall at the site of resection. Could be due to bronchopercutaneous pleurocutaneous fistula. Could be due to what we call lung herniation through the defect, or chest wall abscess. Lung herniation may be congenital at the apex, where we find the lung bulging up, and this is called the septum fascia, defective septum fascia, or sometimes due to trauma. So if we have abnormal collection of air outside the proposed line of the lung, it could be due to cutaneous pleurocutaneous fistula, could be due to lung herniation, extension of the lung, or a chest wall abscess. And notice that lung hernia could be congenital, but this is common here, or it may be due to post-trauma or post-resection, as in this case. Pleural masses, of course, it may be primary pleural masses, asbestos plaque or pleural colloaq, subpleural masses as lipoma or rib lesions, localized fibrous tumor of the pleura itself, and malignant mesothelioma. But metastases are more common from lung, breast, ovaries, colon, and even lymphoma. So we can find the asbestos plaques, we can find the pleural colloaq, we can find subpleural masses not related to the pleura but adjacent to the pleura as rib lesions or lipomas. From the pleura itself, there may be benign lesion as localized fibrous tumor of the pleura or malignant mesothelioma, which appears usually as either one mass or loculated ossy mass or associated with massive effusion. Secondaries are more common. Lymphoma extension is known. Asbestos plaques is bilateral, parietal, diaphragmatic, fibrous, calcific changes seen as like plaques like this, and here starting subpleural associated with pneumothorax. Fibrothorax or massive fibrothorax or massive calcification is called the pleural colloaq. This is the appearance. It's not uniform in both sides. It is only restricted to the involved side. It's unilateral, thick, displaced inward from the chest wall, related to the pleural infection, usually TB empyema. So fibrothorax due to TB is usually unilateral and is called dense, causing dense calcific changes away from the chest wall due to partially collapsed lung, and it appears as an opacity more peripherally dense, and this is called the pleural colloaq or the TB fibrothorax. Here we have right pleural based opacity of fat. The differential diagnosis is of course anodule, bronchogenic, peripheral, but more if it is fat and you are sure about fat. So pleural lipoma or fibrous tumor of the pleura maybe, because here smaller the lesion, the difficult will be the density to assess. Pleural lipoma is the most common pleural benign tumor. Pleural lipoma is the most common pleural benign tumor. Subpleural lipoma, another case of subpleural lipoma, the most common tumor, the most common benign tumor. Lobulated pleural thickening could be due to empyema infection, but more is due to malignant mesothelioma or pleural metastasis. Of course, direct invasion or secondary hematogenous could be. Both can do. Don't forget that multiple myeloma involving the ribs can extend into the pleura as bulging, and that thalassemia may cause bone expansion and extramedullary hemopiesis. Mesothelioma is caused due to asbestos. The inhaled fibers are deposited in the subpleural lungs and produced through the visceral pleura. Pleural irritation leads to hyperplasia, metaplasia, and eventually mesothelioma. The differential is metastasis and benign asbestos-related diffusion, multiloculated empyema, and invasive tumors. Of course, any multiloculation should raise the possibility of mesothelioma if you exclude empyema. Here we have bossy outline of the pleura, and this is the typical nodules in pleural mesothelioma with associated effusion. Of course, we can say that it is encasing the lung, So if you have masses bulging into from the pleura, continuous with the pleura, with the outline, bossy outline, encasing the lung, associated with effusion, no history of empyema, and no history of primary, please consider it mesothelioma till otherwise proved. Another one, something encasing the lung, showing bossy outline. It is continuous with the pleura, continuous with mediastinal pleura, diaphragmatic pleura, costal pleura, even into the fissure. So these masses are definitive for mesothelioma. Thank you.